Hello and welcome to part 3 of this endocrine revision series. Today we're going to be having a look at some more of the principal organs of the endocrine system. We've already taken a look at some in video 1, in video 2, and now it's time to have a look at the sex organs, so the testes and the ovaries, the thymus gland, and as well have a look at calcium and phosphate metabolism in a little bit more depth with regards to the thyroid gland. So in terms of sex organs, broadly speaking, we can think of them as ovaries in females and testes in men. And this video is going to really focus on the hormone actions with regards to these organs, because we're going to talk about the ovaries and testes in a lot more detail in the urogenital videos. So in terms of women, we can think about ovaries and their production of estrogen. So estrogen acts on the ovaries themselves, the uterus and the pituitary gland. So it allows the control of puberty and the menstrual cycle in females. It also stimulates the production of luteinizing hormone, as well as suppressing the production of follicular stimulating hormone within the pituitary gland. On the other hand, the ovaries can produce progesterone, and in this case it acts on the uterus to maintain the lining of the womb during pregnancy, but it can also suppress follicular stimulating hormone production in the pituitary gland as well. In terms of males, we've got the testes, of course, and testosterone production, which controls puberty in males and the development of masculine characteristics. So let's have a look in a little bit more detail at the ovary. So this is a diagram you'll probably be familiar with, and it's the development, of course, at primary follicle all the way through until the egg is released at ovulation, and then the development of the corpus luteum thereafter. But of course all of this happens because of hormones, and it's actually these cycles which are really important. So the two cycles to be aware of are the ovarian cycle and the uterine cycle. The uterine cycle characterizes a breakdown of the uterine wall and then the regrowth of the uterine wall because of hormones such as estrogen, progesterone, LH and FSH. Likewise, the ovarian cycle, what we've just looked at in that previous diagram, is really important. For example, that surge of LH in the middle is what causes that ovulation to occur. So linking in the hormones to these cycles is what's really important about the ovaries. So the ovaries produce and release, as we've said, two groups of sex hormones, the progesterones and the estrogens. So there are three major estrogens you need to know about, so estradiol, estrone and estriol. So these substances work together to promote the healthy development of female sex characteristics during puberty and to ensure fertility is maintained. To a lesser extent, the ovaries also release the hormone relaxin prior to giving birth. So another minor hormone is inhibin, which is really important for the signaling of the pituitary to inhibit FSH secretion. Moving on to the male aspect of the sex organs, the testes secrete testosterone, which is necessary for proper physical development in boys. In adulthood, testosterone maintains that libido, that muscle strength and that bone density, in other words, those masculine characteristics. And therefore any disorders of the testes are usually caused by having too little testosterone production. An example of this is the so-called andropause in later life in men, when there's a dysregulation of the levels of hormones. Leydig cells in the testes also produce androgens from cholesterol. FSH in men supports the sperm maturation by stimulating Sertoli cells, which are those supporting cells in the testes. So remember, testosterone is a primary androgen and it stimulates and maintains masculinity and therefore has a key role in puberty. Moving on, we can look at the thymus. So this is mainly present in childhood and not in adulthood. So you tend to see it in children but not in adults. And it's more of an immune system organ than an endocrine gland really, but it does have one particular endocrine function which we need to be aware of. As we said, it's located up around the mediastinum, particularly in children, and it secretes thymosin, which is really important for stimulating the development of T cells. So really it is linked to the immune system as opposed to the endocrine gland. But really what's important is actually it is secreting a hormone to cause the stimulation of the development of T cells. So that thymosin is a hormone, and therefore it is technically part of the endocrine system as well. So this is the thymus, which I suppose looking at it kind of looks a little bit like the thyroid, and probably you'll get it confused at some point, but the thymus is lower down in the mediastinum and a much larger structure really, and it's only really present in childhood. On the other hand, thyroid gland a little bit higher up near the cricoid cartilage, much more important role in terms of calcium metabolism, and it's present all through your life. So then talking about calcium and phosphate metabolism, it's all down to a system of negative feedback, and therefore as levels of a substance fall, you want to try and find a way to raise it back up again. And of course vice versa. If you get too much of something, you want to reduce it. And we do this through this simple negative feedback loop. In other words, you have a stimulus detected by a sensor, relayed up to the control, and then the effector returns it to normal. And it's only when that stimulus begins again, in other words, it's out of the normal range, that it's detected and changed. So calcium then, it's critical that we keep it in a really tight normal range, and any deviations above or below that normal range can lead to serious consequences. And two familiar terms to be aware of are hypocalcemia, in other words we've not got enough calcium in our blood, and hypercalcemia, where we've got a too high concentration of calcium in the blood. These two terms here can be applied to a lot of things in medicine, so hypo, not enough, and hyper, too much. So where is all this calcium? Well, it's in three locations that we need to know about. You could have intracellular calcium, and a large majority of calcium is within the cells, in the mitochondria, in the endoplasmic reticulum, acting as a signalling molecule. On the other hand, calcium's in our blood, and it's in our extracellular fluid, flying around our body, bound to proteins. Alternatively, the most known location of calcium is in the bone, of course, and 99% of the calcium is actually tied up in the mineral phase, but we have 1% which has remained in an almost like pool that's rapidly exchangeable with the extracellular calcium, and this is how we increase and decrease the calcium in our blood, as we'll see in a moment. So what about if we've not got enough calcium? So hypocalcemia. We need to increase the calcium levels, and there are several ways we can do this, but I'm going to summarise it in a much more simple diagram. So, parathyroid hormone is released from the parathyroid glands on the back of the thyroid, and PTH causes several things to happen. It increases bone resorption, releasing bone calcium into the blood and increasing serum calcium levels. In other words, it increases bone breakdown. It increases the calcium and phosphate reabsorption from kidneys, and it increases the serum calcium levels that way. And lastly, it converts the inactive form of vitamin D to active vitamin D, which aids the whole process. So when we convert inactive vitamin D into active vitamin D then also increases bone resorption. It also increases absorption of dietary calcium and phosphate. So vitamin D is really important, and we get vitamin D from several sources, but we always get vitamin D in the inactive form, and therefore our bodies need to activate it. So sunlight hits our skin, and also we eat fish, milk and eggs as the two main ways of getting vitamin D. But both of these are inactive, so vitamin D3, also called cholecalciferol by its scientific name, and cholecalciferol travels to the liver. From the liver, cholecalciferol, the inactive form, is acted upon by 25-hydroxylase from the blood, and therefore is converted into 25-hydroxy-D, in other words calcidiol. This is also inactive, so not very useful, and therefore it travels to the kidneys. Calcidiol in the kidneys, therefore, PTH from the parathyroid glands, parathyroid becomes alpha-1 hydroxylase, and therefore acts on the calcidiol. So it's a whole cascade of acting on one thing, really, and causing something else to happen. So one alpha hydroxylase from the PTH acts on calcidiol, and calcidiol is converted into 1,25-hydroxy D, in other words, calcitriol, and this is finally the active form of vitamin D. So this also helps in terms of regulating calcium levels, because vitamin D also promotes that bone breakdown. It also promotes reabsorption of calcium from the gut, but don't forget PTH does both of those things, but also increases reabsorption of calcium from the kidneys before it is passed out as urine. So this is an overall diagram pretty much summarising that inactive vitamin D coming in and the processes that occur to get it to this active vitamin D form. If you don't understand any of the previous slides, it's pointless looking at this yet. It's easy to look at the previous slides, and then when you've got it all in your head, you can put it all into one simple diagram like this. What about if you've got too much calcium then? Well, the opposite's going to happen, and this time calcitonin is released from the parafollicular cells of the thyroid gland. So calcitonin therefore does the opposite. It promotes the transformation of calcium in the blood into the bone. It uptakes calcium. It inhibits the reabsorption of calcium and phosphate in the kidneys. In other words, it allows calcium and phosphate in the blood to be excreted into the urine. And an obvious factor here, PTH release is inhibited. So where you have calcitonin release, you have PTH inhibited, and where you have PTH, you have calcitonin is inhibited as well. So therefore it's all about negative feedback. If you've got too much of something, you want to bring it down. If you've got too little of something, you want to bring it up. Phosphorus also has an important role in cellular metabolism, and it's the source of energy in our cellular reactions. It's also a component of phospholipids in membranes, so remember that phospholipid bilayer, phosphorus is a part of that. And likewise, we can use these clinical terms, hypophosphatemia or hyperphosphatemia, to indicate whether the blood phosphate level is low or high. Now, if you focus on bone, so this is a link to MSK, remember bone is a constantly regenerating substance. And osteoclastic activity is the breakdown of bone, and osteoblastic activity is bone formation. So remembering that calcium is stored in the bone, PTH really wants to increase osteoclastic activity. It wants the bone to break down, it wants the calcium to be released from the bone into the blood, and therefore calcium in the blood increases. On the other hand, calcitonin does the opposite. It decreases osteoclastic activity, or increases osteoblastic activity really, by causing the bone to stay formed, and therefore calcium stays in the bone, or calcium taken up from the blood into the bone, and therefore you have less blood calcium. So in terms of summary, we're going to go over the 3 questions we started these videos with to see if you've completely understood the videos, or if you picked anything up that's new. But also then there's 2 harder MCQs at the end if you want to have a go at those. So again, I'm not going to pause the video, but you can, and to give yourself time to think. So where are glucocorticoids produced? Hopefully now you are fully aware that glucocorticoids are produced in the zona fasciculata, which is one of those 3 layers of the adrenal cortex. So remember the GFR of the adrenal cortex, the glomerulosa, the fasciculata, and the reticularis, so salt, sugar, and sex. And actually, of course, glucocorticoids refer to sugar in cortisol from the fasciculata region. Question 2, then, what do T3 and T4 do attach when they travel in the blood? Hopefully now you're aware it's thyroid binding globulin. TSH is of course what's released from the pituitary gland to stimulate the thyroid to release T3 and T4. Colloid is the substance which is within the thyroid cells, and iodine is of course what's binding to tyrosine to form T3 and T4, which is then bound to TBG in the blood for transfer. And question 3, what cells of the pancreas produce glucagon and insulin respectively? The answer here are alpha and beta cells, and this has been relayed many times now. So alpha cells produce glucagon, insulin is produced by beta cells, and delta cells secrete somatostatin. For bonus points, try and think about what those substances do. So what do insulin and glucagon do? So for some harder MCQs then, what does ACTH promote the release of? So remember that's adrenocorticotropin hormone. Does it promote the release of epinephrine, testosterone, aldosterone, or cortisol? So the answer here, of course, is cortisol. As previously discussed in the other question, remember ACTH is released from the anterior pituitary. It acts upon the adrenal cortex, so particularly the zona fasciculata, which produces glucocorticoids, aka cortisol. And cortisol is then released. Cortisol causes increased fat and protein breakdown, so lipolysis, increased blood glucose levels, and has anti-inflammatory effects as well. So one more question. The thymus aids the differentiation of what type of cell? Is it B cell, T cell, red blood cell, or antigen presenting cell? So this was covered in this video. And remember, an easy way to answer this one is, well, what immune cell needs activated in order to carry out its function? And the answer is, of course, T cells, because T cells are secreted in a pretty inactive form and need activating by the hormone thymosin, which is released from the thymus. So that's everything for this video. If you do have any feedback, please do let me know. And if you have any questions also, please do get in touch. And thank you very much for listening. I hope you found all of the videos useful.